Hello, my name is Andres Icasa and I'm going to talk about acute kidney injury in patients with cancer. First, we're gonna go with the definition. Acute kidney injury is also known as acute renal failure. It's a sudden episode of kidney failure or kidney damage that happens within a few hours or a few days. Acute kidney injury causes a buildup of waste products in your blood and makes it hard for your kidneys to keep the right balance of fluid in your body. Acute kidney injuries also affect other organs such as the brain, heart, and lungs. Patients with cancer are at risk for acute kidney injury that is caused by sepsis, direct kidney injury due to the primary cancer, metabolic disturbances, the nephrotoxic effects of anti-cancer therapies, or hematopoietic stem cell transplantation. Older age, more than 65 years, female sex, and coexisting disease processes, including chronic disease, diabetic kidney disease, and a volume depletion due to vomiting or diarrhea, or renal hypoperfusion due to cardiomyopathy, cirrhosis, or the nephrotic syndrome, increase the risk of acute kidney injury.
So acute kidney injury is defined by the abrupt loss of kidney function, retention of urea and other nitrogenous waste products, as well as the dysregulation of extracellular volume and electrolytes. Before we move on, though, there are some important terms that I really want you to understand so you can better understand the cases that we're going to be talking about. The first is creatinine. Creatinine is a breakdown product of creatine phosphate in muscle. It's filtered completely by the kidney and it's not metabolized and therefore is used to estimate kidney function and filtration. It does have an inverse relationship to function, meaning that the higher the creatinine is, the lower the GFR or filtration rate is. You will also hear the word BUN or blood urea nitrogen. So urea nitrogen is formed from the protein catabolism by the liver. It's filtered by the kidneys and it's used as an additional measure of kidney function. Although a high BUN generally reflects lower filtration, there are some caveats when it comes to BUN, and it can increase independently of kidney function. This includes things like glucocorticoids or steroids when our patients are on steroids, tetracycline antibiotics, or reabsorption of blood from the GI tract. In each of those instances, the BUN may rise, and the creatinine might be normal, as well as kidney function. So do keep that in mind as we're talking about BUN. Oliguria is another important term to know. Our patients are commonly oliguric when they develop acute kidney injury, and this really means that our patients are producing less urine. Typically, it's defined as less than 500 mils of urine output within 24 hours, but do keep in mind there are a few definitions that will define oliguria as less than 400 mils in a 24-hour period of time. Finally, there's anuria. Anuria is defined by less than 100 mils of urine output in a 24-hour period of time. And this is essentially one of the worst signs of acute kidney injury because our patients are essentially not producing any urine. If you remember nothing else from this lecture, do remember that acute kidney injury is significant. In our critically ill patients who develop AKI, their mortality is increased between 40 to 60% at 60 days, and their hospital stay is prolonged.
Now we're gonna talk about the applications in medicine. Both the short-term and long-term outcomes of acute kidney injury in patients with cancer are poor, with one study showing that 60-day survival rate is of only 14%. However, selected patients can benefit from aggressive care. Thus, decisions regarding the initiation of dialysis are complex and require input from the entire care team to assess the reversibility of the acute injury, the longer-term cancer prognosis, and the quality of life before the acute injury. Furthermore, the patient's preference must be considered in the decision regarding dialysis initiation. The process of shared decision-making is recommended for working through the issues regarding dialysis initiation in these complex situations.
To make it simple, the causes of acute renal injury or kidney injury can be classified into three types. These are pre-renal, which is as a result of decreased perfusion to the normal kidney, intrarenal, acute kidney injury, and post-renal, also called post-obstructive acute kidney injury. Pre-renal acute kidney injury is also known as pre-renal azotemia. Pre-renal causes include hypovolemia, reduced cardiac output, like in cardiogenic shock, for example, or reduced effective circulatory volume, such as in congestive heart failure or liver failure. Essentially, these causes lead to reduced blood flow to the kidneys, and so you have a reduced hydrostatic pressure. Thus, you get reduced glomerular filtration. Another cause of pre-renal acute kidney injury is impaired renal autoregulation due to the use of nephrotoxins such as non-steroidal anti-inflammatory drugs. Now, non-steroidal anti-inflammatory drugs, they actually cause vasoconstriction to the afferent arterioles. And so this will result in reduced hydrostatic pressure, resulting in reduced glomerular filtration. ACE inhibitors or angiotensin receptor blockers causes vasodilation of the efferent arterioles, which is useful at times, but in renal injury, it actually amplifies the renal injury because it reduces the hydrostatic pressure and reduces glomerular filtration rate. Finally, cyclosporin also causes acute kidney injury. Now, by definition, the pre-renal acute kidney injury we talked about doesn't actually involve the parenchyma, doesn't involve the actual nephrons really. So pre-renal acute kidney injury is usually reversible. However, prolonged pre-renal can lead to ischemic injury, causing intrarenal acute kidney injury. And we'll talk about intrarenal acute kidney injury later, but first, let's talk about post-renal causes of acute kidney injury. Post-renal acute kidney injury is also known as post-obstructive acute kidney injury. And it's essentially obstruction anywhere along the urinary tract from the renal pelvis, ureter, bladder to the urethra.
Now we're going to talk about the pros and cons. There are not many pros for this disease in conjunction, cancer and kidney injury, but one pro is that patients with cancer who are critically ill have the highest risk of acute kidney injury, but at an incidence of 54%, particularly patients who have hematologic cancer or multiple myeloma and those with septic shock. This means that the ones more affected are only the critically ill. The ones that have cancer but are stable, they're not going to be affected that much. In the cons, we have that acute kidney injury in patients with cancer is associated with substantial morbidity and mortality. Acute kidney injury increases the risk of toxic effects from systemic chemotherapy, jeopardizes the continuation of cancer therapy, and limits the patient's participation in possible life-saving clinical trials.
The last section of this video will deal with the rifle criteria of ARF. The word rifle stands for risk, injury, failure, loss, and end-stage renal disease. All of these 5 words represent a grade of acute renal failure in increasing order of severity. In the risk category, the serum creatinine rises 1.5 times of baseline, whereas the urine output of the patient falls less than 0.5 milliliters per kilogram per hour for at least 6 hours. In the next category, the injury, the serum creatinine rises 2 times of baseline, whereas the urine output falls to 0.5 milliliters per kilogram per hour for at least 12 hours. In the next category, the serum creatinine rises 3 times that of normal, whereas the urine output falls to 0.3 ml per kilogram per hour for at least 24 hours. In the loss category of rifle criteria, if the acute kidney injury persists for at least 4 weeks, it is included in this category. And end-stage renal disease is when end-stage renal disease persists for 3 months. That is when you require a renal replacement therapy like dialysis for at least 3 months. Thank you so much for watching this video.
That was the rifle criteria used to classify acute kidney injury. And now we're going to talk about the issue applied in Ecuador. We have that in Ecuador, we have 16,278,844 people, and it is estimated that patients with kidney failure will be more than 11,460. That's a considerable amount. There are 157.2 cases of cancer per 100,000 inhabitants in Ecuador. So we also have a high rate of cancer. And now we know that there are many people in Ecuador that suffer from kidney disease, and many cases many of these cases start in patients with cancer.
We know that acute kidney injury is on the rise, but little is known about its incidence or outcomes or risk factors in patients with cancer. So we, working at MD Anderson Cancer Center, looked at admission of patients into the cancer center over a 3 months period in 2006. We found that the incidence is much higher than compared to the community admission of patients for medical reasons. Cancer patients had about 28% acute kidney injury during the hospitalization. That included 14% who had when they were coming into the hospital, and 14% who developed acute kidney injury while in the hospital. Again, little is known about the outcome of these patients who developed acute kidney injury. And what we found was that patients who develop acute kidney injury, the cancer patients in the hospital, has about 5-fold increased odds ratio for mortality. They're all 3 times more likely to stay in the hospital as well. And there are certain key risk factors were identified, such as the presence of sepsis, the utilization of antibiotics, the presence of hyperglycemia. So all these are indicating us that we may be able to look at these things more closely, may be proactive in identifying these risk factors, and to see whether we can reduce the likelihood of developing acute renal failure in cancer patients admitted in the hospital. The hope is that doing so, we may be able to reduce the higher mortality associated with acute kidney failure.
Now we have the conclusion. In conclusion, now we know that acute kidney injury in patients with cancer has diverse causes and negative outcomes. Efforts to prevent acute kidney injury in this patient population are likely to improve outcomes and allow patients to reap the benefits of advance in cancer treatments. Now we're going to finish with an example of acute kidney injury in the case of a nephrectomy because of a tumor in the kidney.
Now, with nephrectomy, acute kidney injury is incredibly common. In the days where full radical nephrectomies occurred, 40 to 50% of patients had some form of acute kidney injury. Now that partial nephrectomy, or really nephron-sparing nephrectomies, just removing the tumor itself, is occurring, you still see a relatively high incidence of acute kidney injury, approaching 20%. And it's not surprising, because many of these patients, when you look at their non-neoplastic tissue on renal biopsy, almost all of them have significant renal signs of CKD with significant fibrosis. So removing just small amounts of nephron mass seems to really affect these patients in very severe ways. So these patients, even in the age of nephron-sparing surgery, have an incidence of some form of acute kidney injury that ranges about 20%.
Thank you very much.